Right, Sally, let's get going. Good evening, everyone, and thank you for joining us in our series of webinars from OCL Vision. Thank you to everyone who has logged in and joined us for the previous webinars, and a huge welcome to those of you that are joining us for the first time today. And for those of you who are regular viewers, you'll have heard the next bit of spiel, but just a small bit of housekeeping. All these webinars are recorded and they are available to view on our YouTube channel, OCL Vision. There is one CET point available for viewing this webinar if you have logged in with the link that you received when you registered. And that one point is for optometrists, dispensing opticians, and therapeutic prescribers. This lecture will run for about 45 minutes or so, with questions at the end. So if you do have any questions, please pop them into the Q&A box on your phone at the bottom of the screen, and we will get through as many as we can at the end of the lecture. So today's speaker is our brilliant Sally Ameen. Sally is a consultant ophthalmic surgeon with us at OCL Vision and also at London's Imperial College Healthcare NHS Trust. She's an expert in the management of all forms of glaucoma and a specialist eye surgeon that performs all glaucoma surgery and is highly trained in complex cataract surgery and emergency ophthalmology. Sally, I'll head over to you. If you want to share your screen, we'll get going.
Thank you, Pavi, for that very lovely introduction, and welcome everyone tonight for today's webinar, especially on really the first day of sunshine that we've had this year at all. So I hope you find this talk enjoyable and useful, and just like Pavi said, at the end of the talk I'll be more than happy to take on any questions and answer them for you as well. So the title of today's talk is about the latest developments within the glaucoma treatment pathways for patients that are available. The aims is really to, like I said, to describe the latest development in the treatment modalities of glaucoma and how these new changes affect the management of current and new patients and what's likely to come up in the near future. The question to ask is why change in the first place? As we know, glaucoma is a disease of the aged, so we all have increased number of glaucoma patients across the UK, whether that's in the NHS or private sector, with a higher life expectancy of all these patients who are also more independent and living for longer periods of life, a healthy living. There is an increased awareness of the condition, so the patients have better knowledge of the conditions and of the possible treatment options that can be made available for them, and high expectations from those patients and the clinicians to provide the best standard of care and preserving vision and preventing any visual loss from glaucoma. And one of the big factors that caused a massive change in the pathway of care for glaucoma patients is COVID-19. So as we know, over the last 15 months, there's been a massive lockdown on care that's been provided for patients, especially those who are deemed to be of chronic disease, and the inability to review those patients, and also the possible treatment options available for them. So things that you would probably consider 15 months ago, you may not be able to due to possible repeat of patient follow-ups and the ability to cope with the post-drop regime, for instance, following surgery. So if we just start by looking at newly diagnosed glaucoma patients and how we manage these differently now. So as you know, for those who are interested in glaucoma clinicians and surgeons are very much research-based and evidence-based in the type of care that we provide for our patients. So recently there's been a study called the LIGHT trial that was published in the Lancet, and it looked at the effects of the selective laser trabeculoplasty, or SLT, versus topical medication as a first-line treatment for patients for ocular hypertension and primary open-angle glaucoma. And it showed that actually the efficacy of the laser treatment over a period of over 36 months was just as effective as first-line treatment, but also because the patient was essentially drop-free and the pressure was controlled without the use of any drops, the quality of life questionnaire showed that they were understandably a lot happier. They required fewer visits into the clinic because of the stability of their pressure, and that in itself not only reduced the cost to their carer, but also reduced the number of visits, which allowed opening space to see other patients as well. So from that point onwards, there has been a recommendation for patients who are suitable, so if they have an open angle, to recommend using selective laser trabeculoplasty as a first-line treatment. We will talk about the laser later on and how it's administered and how it actually works. So for patients with narrow angles or risk of angle closure, so again, as you know, most of the time these patients are picked up incidentally, so they come into your optician practice for their routine test or new glasses, or they've just changed opticians and you're meeting them for the first time, and they are on most parts completely asymptomatic. And there has always been a question of, well, should we prophylactically perform laser peripheral iridotomy on these patients, or should they be left to be monitored? And again, a recent trial called the ZAP trial, again published in The Lancet, looked at what happens to those patients. They used one eye as a control and the other eye underwent peripheral laser iridotomy as a prophylactic treatment. And although the laser treatment group showed a lower risk of developing angle closure within the 5-year period of follow-up, actually the overall risk of developing any kind of problems in the untreated eye was so low that it was deemed unnecessary, or the recommendation was it is unnecessary to perform laser peripheral iridotomy prophylactically on patients. There's just a little picture there of essentially how they separated the groups, and the numbers there I appreciate is quite small, but I can send the information around for whoever's interested. So that, again, as you can imagine, has really changed practice and recommendation for patients. So when normally patients come to see me with narrow angles and are completely asymptomatic, I quote this paper for them and tell them essentially there is a 70% chance within their lifetime that they will not develop any problem, but having the laser will reduce, increase the chance to 90%. But again, like I said, the chances of developing problem is quite small. And then a few years back, there was the EAGLE study that looked at patients over the age of 50 with primary angle closure and raised pressure, but it's completely asymptomatic, and assessed peripheral iridotomy versus clear lens extraction. So these are patients that had non-visually significant cataracts. So, their vision was 6.6 and sometimes even 6.5, but they had a closed angle, and compared doing early cataract surgery purely to open up the drainage angle versus peripheral iridotomy. And what it showed ultimately over a period of a few years, that again, the patients who underwent clear lens extraction were much better off than those who ended up with a peripheral iridotomy, not only for the patient care, but also cost to the services that was providing them. So as you can see, these 3 landmark studies over the last 5 years have really changed practice of what we recommend for patients who come and see us as new patients. So if the patient, for some reason or another, was started on a topical treatment as opposed to all the above that we've discussed, always aim to use a single agent, and the first line recommendation is a prostaglandin analog, and ideally preservative-free. There's a number of reasons why preservative-free medications are recommended. First of all, they're a lot more comfortable for the patients, which increases compliance. Then they don't tend to irritate the eye, so the conjunctiva stays very healthy. They don't get the usual irritation and follicular reaction that can damage the conjunctiva over the years. Prostaglandin analogs have really no systemic side effects, and then the redness that appears with the use of them usually subsides within the first 4 to 6 weeks, and it's less so with the preservative-free agents. And also don't forget, these drops are only administered once a day, so again, in terms of the drop load to the patient, it's much less. If that treatment is simply not sufficient, then you can do combined medication. So normally it's a combination of a beta blocker with another medication, so beta blocker with a prostaglandin, a beta blocker with a carbonic anhydrase inhibitor, and again, always aim to use preservative-free drops when it is required, and the drop that would need to be administered as few times as possible. So that's the recommendation. Now we're trying to stay away from the preserved medication because we know over time they really do cause a lot of damage to the eye, and in a lot of these patients who then end up going on to need filtration surgery, the final outcome of their filtration surgery and success rate is very dependent on how well their surface is doing. So if they have a lot of scarring from using preserved drops for a long period of time, then it's not ideal for their recovery. So we get to monitoring. How do we monitor these patients and how do we assess progression of glaucoma? Because as we know, glaucoma is known as the thief of sight. Pretty much all of the time patients present, they are completely asymptomatic and it's picked up incidentally. So these patients are monitored now always with objective measures, and that would include an OCT scan of the disc, and that will be the one done over here. There's quite a few number of machines that are available to do that. And then some have a serial progressor that can show you a progression analysis over a period of time as you take serial scans to see if there has been any change. So for instance, a patient presents with, just like the one we have here, asymmetrical optic disc that very obviously probably suggest a disease in one eye, but then the other eye. But if it was more subtle than this and you're not 100% sure, then you repeat the scan in 6 months' time and you've got an objective measure of the neurofiber layer to see if there has been any change. So is this physiological versus the fact that is actually definite glaucoma changes. In some units and actually even some optician practices, there are anterior segment OCTs. So you can see in the top picture, that's looking at a closed angle. So you can see the iris is bowing forward. So that's iris tissue here. That is cornea here. And the drainage angle is the space here between your cornea and the iris. And you can see that's closed. This patient underwent a clear lens extraction. So you can see the cataract or the lens opacity would have been in that space there. You can even appreciate the corneal incision just here, very light line, and you can see how suddenly, hey presto, the angle's now wide open, and essentially they've been cured of having any kind of glaucoma issues. And then you've got the visual field, which ultimately that is what it's all about for the patients. Ideally, Humphrey's visual field, a 24-2 is more than sufficient. And again, quite a few of them have glaucoma progression analysis software that can compare visual fields, a series of them, and can tell you if there's any evidence of progression over the years. So what's happening in the future in terms of monitoring, there's a lot of talk and I think availability of some disc OCT new machines that can actually predict where the visual field defect would be based on the defect in the nerve fiber layer that's picked up by the OCT. So that's very exciting when it does come in, and it may even take away the need to do visual field over the next 10 years. We know we all have these patients who are simply unable to perform visual fields, just always have lots of false positives or false negatives, and it becomes very frustrating and you are unable to interpret the results. So again, if we can develop a more objective measure of progression, that will be ideal, and that will be definitely something coming in the future. So what are we doing about follow-up of stable patients? So like I said, with regards to COVID, we've all been faced with this large number of patients waiting to be seen, most of whom are actually stable, but without physically seeing them and assessing them both objectively and subjectively, you are unable to reassure the patient that they've come to no harm. So everyone's been thinking outside the box and trying to think of ways of how we can bring in these patients and see them and ensure that they are okay, and the ones who are not okay, to make sure they can be seen sooner, instead of clogging up the clinics of all the patients that need to be coming in. So one option that's been tried and tested for quite a few places, even before COVID came in, is the virtual clinics. So what tends to happen is the patient comes in, sees a technician or even an optometrist, depending on where you are, and has their pressure checked, usually either with an eye care or even a contact tonometry with a Goldman, has a disc OCT and a visual field. All the data is then uploaded onto some form of software. So that could be anything from Medisoft or your own personal software. It's been taken up by a certain company and then reviewed virtually by a consultant who puts all the results together and creates a management plan based on how that patient is doing. So if they are, fingers crossed, completely stable and have shown no change over the years, then they get seen every 9 to 12 months. Or if there's been any change, if it's mild, then you recommend to see them within 4 months. And if it's moderate to severe, then you see them within 2 to 3 months. There has been a lot of talk about outsourcing to local units, whether or not that's, say, if you work within a big central hospital and you outsource to the other units, that normally feeds into the hospital or actually local optometrists. But obviously the main issue here has been data protection, and how do you find a platform on which you can upload all these scans safely to make sure that this data is protected. So within the NHS, obviously everything is encrypted, and that problem is solved. Outside the NHS is slightly more difficult, but again, I think it's quite promising, and I think it will be something that everybody will be looking at, and it's just better for everybody. It's better for the patients, it's better for the clinicians. People don't have to travel far, they don't have to go across, for instance, London, to go from one place to the other, or even any part of the country, and can be seen more locally, minimize their travel, minimize contact with other people, and reduce the risk of them developing any COVID contact during their journey. Now, I've put the iVan between quotes, and this is something new that we are trying out at the Western Eye Hospital. Essentially, it is a van that has been revamped, shall we say, to try and accommodate to see patients on there. So it is a mobile unit which has all the instruments that we talked about. So it's got an OCT, it has a visual field, it's got visual acuity lanes, and obviously we'll have a staff member that can do all this. The great thing about it, because it's mobile, the unit can be moved between sites. So again, into the future, it'll be something interesting to see whether it takes on, and actually it will be a mobile eye clinic that can assess patients virtually, and you can even argue that you can have a doctor on site that can see any emergency cases that are picked up on the day and treat them accordingly. But going forward, it'll be exciting to see if this will be something that will be more done across the country. So moving on from conservative management. So what happens if it doesn't work? And then you're considering surgical options. And why would that happen in the first place? So progression of the disease, which happens in quite a few patients, despite the patient having successful SLT and maximum topical treatments that they can tolerate. Having multiple drop allergies, that happens again quite frequently, especially the patients who have used the preserved medication over many, many years. All of a sudden, they are unable to tolerate any of the medications that are given to them, or the simple wish to be drop-free. So again, like I said, quite a lot of their patients, even though they are on the older age group, are still very active. I appreciate right now travel is more restrictive, but I have had quite a few patients that travel around the world and really don't want to be restricted in their movements, because they constantly be needing to be putting drops or running out of drops, or coming back for regular visits, or simply the inability, so the other extreme, to put the drops in. So again, elderly patients with arthritis within their hands, unable to physically instill their drops in, and the drops are no longer an option. So the biggest change and move within the world of glaucoma recently has been MIG surgery, which stands for minimally invasive glaucoma surgery. And these are essentially micro implants that are inserted inside the eye, either as a standalone operation or combined with cataract surgery. They do offer a moderate IOP reduction, so the kind of essential quoted number is about 30% of the starting IOP, but really in practice it can be up to 40%. They have a high safety profile. So in terms of when I speak to the patients about them, the worst thing that can happen in most of them is essentially them not working, but the efficacy again is very high. And most of them, but not all, does actually target the outflow pathway. So I always tell patients when they come and see me, glaucoma, to think about it is essentially all about a closed system and regulation of that closed system. So you have a tap that is on, that produces aqueous fluid, and you've got a plug hole through which the fluid comes out. The pressure goes up either because the tap is on too much for some reason, or the plug hole is restricted. And when we address glaucoma and try and reduce the pressure, which at the moment is the only form of modality of control of the disease, we, again, whether it's drops, laser or surgery, work on those two principles, either increasing outflow of the aqueous fluid or decreasing its production. So everything that's done is again based on those two simple methods. So I'm just going to run you through the current available MIGs, just really to give you an idea of how many of them that are available on the market and how exciting it is right now actually to be a glaucoma surgeon, because it is constantly changing, constantly developing and growing, and it really just, it's really exciting to have so many options to offer to the patients when they do come and see you. So to start off with, is essentially the Eyestand. So that's been on the market for probably the longest period of time. And this is essentially a titanium implant. It's this tiny little thing just here. It's about 50 microns in size, and it's actually the smallest implant that you can insert in the body. That is the actual size of the stent. Honestly, hand on heart, even under the microscope, they're very difficult to see. I've been very fortunate and lucky to be using the Eyestand from its first generation, when it used to be just the one stent and it was a completely different shape and design. Then we moved on to what's called the Eyestand Inject. That's what you're seeing down here, where the design of the stent changed completely, and that's a picture of it there. And the stent comes preloaded onto an injector, and there are 2 stents into the injector, so you always have 2 in. We're now at the Eyestand Inject W phase, which essentially looks exactly the same. It's just this part here, which is the stopper, is a bit wider. But we know in the future we're going to be moving on to something called the Eyestand Infinity and the Eyestand Supra, but we'll talk about that in a minute. And this works on increasing outflow. So the idea is it goes into the trabecular meshwork and hopefully into the collector channel, so bypassing the aqueous fluid outflow resistance within Schlemm's canal. And it does work really, really nicely. And again, can be done either as a standalone or at the end of cataract surgery, or at the start of cataract surgery for some people. So I just wanted to show you a video to give you a vague idea of what happens during a MIGS operation. This is for an Eyestand, but roughly the principle is the same for all of them. So this is a patient that already underwent a cataract operation. We use a gonioscopy lens, which is a direct gonioscopy lens, or called a copy lens. So actually, if you have ever tried gonioscopy before, most of the gonioscopy lenses are inverted. So what you see is actually the opposite view of what you are looking at, not with these lenses. So these are direct gonioscopy lenses. So what you see is what you get. All glaucoma surgeons always operate on the temporal side, and these stents all go into the nasal part of the drainage angle. They just seem to work better. So just to give you a vague idea of what happens, so this is essentially the trabecular meshwork just there. That is the injector. So the stents are preloaded on that. It's got a protective sleeve that you would draw back as you're approaching the site of where you're going to put the stent in. And they normally recommend that you are about 2 to 4 clock hours from each other when you do insert them, really, like I said, to increase the chances of hitting a collector channel and lowering the pressure further. And essentially, it's just firing in. So that's one stent that's gone in, and you get a bit of blood reflex, which is usually a good sign that you've hit collector channels, and you move across about, like I said, 2 to 4 clock hours, and you inject the second one. Sometimes you get quite a lot of bleeding, which is not ideal. This is actually real time. It really takes no longer than 2 minutes to put these stents in once you get comfortable with angle work. So that's the 2 stents inserted, and you just put some viscoelastic just to check that you're happy with the position of them. And I will magnify just to show. So that's the 2 stents sitting very happily within the trabecular meshwork, and they would work beautifully. Once they go in, they stay in for life. They really do work forever. I haven't seen any of them that stop working after any period of time. So they're lovely. Now, something that's slightly different is a Zen. Not something that I use in my current practice because it's simply just the cohort of patients that I have. It's not very effective for them. This is a slightly different kind of implant, and it's a different kind of pathway. So as you can see, it creates an outflow channel between the anterior chamber and into the subconjunctival space. So when you look at it in real life, you can see the tip of it just there outside the conjunctiva, and it's yellow, it's plastic. You can't really see it in the anterior chamber, so you'd have to put a gonioscopy lens in. So sometimes you have a patient that comes in and tells you they've had some kind of filtration surgery and there's nothing to see when you look into the anterior chamber. So the first thing I would suggest that you do, just lift the top lid, because you may just see a little yellow thing poking through just there. They're quite effective for the right cohort of patients, and it's usually patients that have a lower risk of scarring. But like I said, in my current practice, that doesn't seem to be the case. So it's not my go-to kind of kit, especially when there's others that are available that work just as well, if not better. And again, this can be done as a standalone procedure or combined with cataract surgery. So coming on to another one, this is called the HighDress. Now, This is, again, fairly new, probably been on the market for a few years and gone through a few design processes in terms of how to insert it, how long is the actual structure and what material's made of. It's metallic, this one. Again, it comes preloaded onto an injector that you put into the trabecular meshwork and you roll it in, and it goes in and it sits in as a scaffold to open up, again, Schlemm's canal and increase the outflow through the tissues because of the reduction in the resistance. It is 8 millimeters long. So if we go back to the Eyestand, think that's only 50 microns inside. This is huge in comparison. So when you first switch over, it's a little bit scary, but you know, it's just another tool to have in the kit. It does say it lowers the pressure more than an Eyestand. It varies from person to person, but again, that's something that, again, you might see. All these little micro stents that go into the drainage angle, the only way to really see them is by gonioscopy, which I appreciate may not be available to many, but it's just good to know that there are lots of options out there. Now, this is a new thing that's been around on the market recently. It's called the Omni surgical system, and it promises to tackle the 3 points of resistance of aqueous outflow: Schlemm's canal, trabecular meshwork, and the collector channels. I personally don't do this myself, but the idea behind it is you put in a blade that essentially cuts into the Schlemm's canal, so actually cuts the tissues away. Then you feed in a tube that goes all the way around, and then you take that tube out, and it essentially rips all the tissues away, going all the way around. You know, again, at the moment, been around. Some people swear by it, some people absolutely hate it. But like I said, that's the exciting bit about what's happening in glaucoma right now. There are just so many tools to choose from, and some work very well for certain patients and others don't. And it's just good to have all these options on board. Now, I wanted to put the SiPass on here, even though I know it's been withdrawn off the market, just to show you that this is a very fluid, constantly changing domain right now. So this tackles IOP lowering, increasing outflow by going through a whole different pathway into the superciliary space. So it's creating a space that actually goes in almost like causing an iris cleft. So it creates a little space and then the fluid drains in. When we did use it, it worked beautifully well. It's made of plastic, it's about 8 millimeters long. It's got these little fenestrations for the fluid to go through. When the first paper came out, when it was FDA approved at 2 years, it showed a very high safety profile. But then the 5-year paper showed that over the years, if the stent was too far forward, so they have these rings here, and it showed if it was 3 rings forward, what it was doing, it was increasing endothelial cell loss to a rate that they weren't expecting. And because of that, they withdrew it off the market. So that was only about 3 years ago, I think. So it was on the market for a good 18 months to 2 years. And then once the 5-year data came out, they withdrew it off the market. No patient actually came to harm, and none of those who had endothelial cell loss actually had any visual loss to go with it. But again, no one knows what's going to happen to these patients at 10 years, 15 years, 20 years. And that's again a very important point to have and a conversation to have with these patients. So even though these stents are great and they work really well and they're minimally invasive, A, we don't know how well they work, and B, we don't know how long they work for, and C, we don't know what the long-term effects of using them is. This is just something slightly different. So this is the only probable mix that you can put in that group that looks at inflow as opposed to outflow. For those of you who've never seen a picture of this before, this is actually the ciliary body. So endocyclophotocoagulation, or ECP, is essentially the same diode laser that we would use externally to target the ciliary body, but done internally through a probe. So you have a probe that has a camera, an aiming beam, and a laser beam. This is actually the edge of an intraocular lens, and that will be the bag. And what you do is you laser the ciliary body to shut it down and reduce aqueous production. So these are ciliary processes that haven't been treated, and these are the ones that have been treated, and you can see they blanch over. It's very exciting. It works very well. It does cause quite a bit of inflammation. So again, you just have to be careful about the patient selection. Now, moving away from inserting stents to increase outflow, reduce aqueous production, we know or have used sustained release glaucoma medication implants. So at the moment, there's only one of them, and it's really just for bimatoprost. That is the only FDA approved drug, and this is the only FDA approved implant. And as you can see, over a period of about 6 months, it slowly melts away. It's inserted in exactly the same way as you would do with any kind of mixed stent. So you go into the drainage angle, it's kind of anchored into the trabecular meshwork, and it slowly dissolves and reduces the drug. Now, like I said, the recommendations that last for about 6 months, but the studies do suggest that the medication stays in the system for longer than that. But at the moment, it is only bimatoprost that has been licensed. So limited use right now, but watch that space because I'm sure there'll be a lot of changes with this as well over time. Alternative laser treatments. So like I touched on earlier, so the laser treatments for controlling pressure, a selective laser trabeculoplasty for the open angle and peripheral iridotomy for the closed angle. For end-stage glaucoma, so for patients who essentially have lost sight and have a painful eye because of the raised pressure, we tend to use a transscleral diode. But a new exciting alternative is this one, which is the micropulse diode laser trabeculoplasty. Essentially, it's a stronger form of SLT. So this again works on outflow, not an inflow. And the idea is, even though it's directed externally, it causes contraction within the trabecular meshwork and increases outflow. It's very gentle, especially when you compare it to the old standard cyclodiode. It's very effective, but again, we've only got about 18 months worth of data, so watch this space in terms of long-term efficacy of the laser. This was very instrumental during the COVID period when we had all these patients with very high pressures and we couldn't perform filtration surgery for multiples of reasons, either the patient's inability to come in for long operations, inability to have general anesthetic, which is required for certain operations, etc. And we can perform this laser, and we knew for at least a period of about 6 to 12 months, we would be able to control the patient's pressures and then address what happens afterwards when it did happen. So this was a bit of a saving grace for that period of time. So if essentially you required a higher IOP drop, so patients has severe glaucoma with very high pressures, not responding to medication, and you don't think the MIGS is really going to do the trick, so you need an IOP drop of about 50% from your starting line. Really, the only way to achieve that is by filtration surgery. And what filtration surgery means is that you're creating a brand new outflow for the aqueous fluid, usually a big channel. The current bread and butter forms of filtration surgeries that I'm sure a lot of you have seen and heard about is essentially either trabeculectomies or tube surgery. Now, both of these have been on the market for a long period of time. We know they're very effective. We know they work in 99% of the time, and they can work for a long period of time. We've got more than 40 plus worth years of data for trabeculectomies and 20 plus years of data for the current tubes that are available on the market. But both are very big operations. They're very taxing for the patients as well. So they have to use very intensive anti-scarring drops or dexamethasone for a period of 4 to 6 weeks, very regular follow-ups. So usually, so for instance, for trabeculectomies, they're seen day 1 to day 3, week 1, week 2, week 3, week 4. And as you can imagine, that's not suitable for all patients. So again, there's always a look to try and see how we can make this better for our patients. So one of the new exciting implants that have come on the market is essentially a PreserFlow, and that's, I would say, a cross between a trab and a tube. So it still requires something called a peritomy. So essentially what you do is you make a cut in the conjunctiva and then you diathermy any blood vessels onto the sclera and use anti-scarring agents. For most of these cases, we use mitomycin C. And then instead of creating a flap, which is what you do for a trabeculectomy, you would insert this plastic tube inside the eye. And again, a bit like the Zen, it then creates an outflow pathway between the anterior chamber and into this subconjunctival space that you have created. It's bigger in size than a Zen, so that tends to increase its efficacy, and it's made of different kind of material that's coated with heparin and other anti-scarring agents, and the hope is it's less likely to scar. So the nice thing about this is you have a lower risk of developing hypotony, which can happen a lot with trabeculectomies, and you don't have the high IOP spike that again can happen with certain trabeculectomies because you've got an immediate outflow, so you know straight away that it does actually work. It stabilizes very quickly in terms of the pressure and the visual acuity, and they don't need such regular intensive follow-up. So usually you see them again within the first week, and if they're doing well, you can leave them for 3 to 4 weeks, and usually within about 6 to 8 weeks, everything's fine. You will see a bleb with this, so that's why I wanted to show this just there. So that's the little stent that you will see in the anterior chamber. Again, it's a bit yellow. Remember, with the Zen, you wouldn't actually physically see it, and then you have a big bleb on top. So that's the PreserFlow. We've got about 18 months worth of data. It does work in about 95% of the time. And interestingly, the European surgeons, mainly the UK surgeons, have the best results. I think it's just because we're more comfortable with doing trabeculectomies. So this just is just natural for us more than other surgeons across the world. So if for some reason you don't think a PreserFlow is an option, and actually the patient requires a tube operation, so that what would happen with a tube is you would have a plate that normally sits about 10 millimeters back from the limbus, and then you've got a big plastic straw that goes inside the anterior chamber. The main issue with tubes, especially the non-valved ones, so that will be the bar-valve tubes, is hypotony. So you can get very low pressure very early on, and then that's usually counteracted by putting a suture inside the tube lumen to restrict flow. The flip side of that equation is they can get high pressure for a long period of time until you take out that suture. The pull tube sort of addresses this. So you do have this big drainage plate, but the lumen size is much smaller. It's about the same size as the PreserFlow. So it would work very quickly. You don't need to block the lumen, and you'll have a lower risk of hypotony. So again, safer profile. Now, the latest thing that's coming onto the market right now, I've had the pleasure of inserting a few of these tubes myself, is the iWatch. So this is a two-system I don't know what's the word to call it, two-system way of controlling the pressure. So you put the tube in as you would do, and it's a specific design of the tube, fairly similar to the bar-valve tube, to be honest. So still has a big lumen and a big plate, but it's a lot more malleable, so it's easier to use than a bar-valve tube. You would insert that. So again, it will be the same principle again. You would put the tube all the way back 10 millimeters and insert the plastic bit into the anterior chamber. Allow that to settle down, and then there would be a watch, a magnetic watch that is put on the other side of the eye, so supranasally, and connected to the plate. And then with a nozzle on an actual eye watch, you can control the fluid outflows here. If, say, a patient comes to clinic and the pressure is too high, dial it down a bit, opens up the lumen a bit more, and vice versa if the pressure is too low. It's very interesting. I mean, like I said, I've put the tube bit in, and that's absolutely fine. We haven't got to the stage of inserting the magnet in yet, so it'll be interesting how that's going to work. We have been told there's been a couple of snags already. Apparently this magnet gets disabled if they go through any kind of security barriers, which can prove to be quite troublesome. They obviously can't have any kind of MRI scanning, etc. So watch this space, I think, for now. This tube itself is absolutely lovely on its own anyway, as an alternative if you don't want to use a bar-valve tube or a pull tube. So what's next? I think MIGs are still going to be refined. There's going to be a lot of changes coming up in the next 10 years until we get the proper data and see how well they really work. And as you can see, they're all going through module changes and design changes, whether it's because of the surgeon feedback or the patient feedback or the results. Gene therapy is a very exciting area to watch right now. There's a lot of research being done at the Western Eye, looking at gene therapy as a treatment modality for glaucoma, and we may, within hopefully the next 10 years, be able to offer these patients an option of a cure, not just halting their disease. So that will be very exciting. Thank you very much. I hope you enjoyed this whistle-stop tour of all the toys in the kit. And like I said, what I really wanted to show is how exciting glaucoma is as a specialty right now, and how personalized the treatment is for every single patient. It is not just one size that fits all. So you have to look at the patient as a whole, address their needs, as well as the glaucoma. So it's not simply providing one size of medication or one form of surgery or one form of drops. There's multiple options are available, and you tailor make it to the patient, and you work with them as opposed to essentially tell them this is the only thing that's available and guide them through all these different options and the pros and cons of each one of them, and achieve the best possible result for them. I'm happy to take any questions. And again, thank you again for joining me tonight.
Sally, thank you so much. That was absolutely fantastic. I didn't know there were so many different types of MIGs and tubes and everything else that you mentioned going on. So that was fantastic. Thank you so much. We do have quite a few questions, so we're going to get going if you're ready to go.
Yep.
Sally, you mentioned regarding the PIs and how you don't do them routinely anymore. A couple of things.
Yep.
Should we, as optometrists, routinely be checking the angles on asymptomatic patients anyway then?
I think most opticians do from memory. I think even if it's not gonioscopy, but simply Van Herrick, you would be able to pick that up. And what I tend to tell patients these days is, like I said, I quote them the ZAP trial. I tell them the side effects of a peripheral iridotomy. I tell them if you do have it, the chances of you being completely safe within your life is 90%. But actually, if you don't have it, 70%, nothing's going to happen to you within your lifetime. And I leave it up to the patient, depending of who they are. But to be honest, anyone over the age of 50 nowadays, I don't even talk about peripheral iridotomies anymore. I think it's either clear lens extraction or absolutely nothing, because you'll be subjecting them to a laser peripheral iridotomy unless they really are against having a cataract operation. And then you'll find yourself in 18 months to 2 years, you're back where you are, the angle's zipped up again because the lens is still growing and you still have to do the cataract surgery.
So on that note though, however, what if you want to dilate these patients? If they've got cataracts, you've got a poor view into the fundus, or they're diabetic and we're screening them, what do we do with those patients then?
Yeah, so that's a very interesting question. So that's when, again, I go back to the point of tailor making the treatment to the patient. So those are the patients that would probably advise to have some kind of treatment. So if they don't want to undergo clear lens extraction because they're happy with the vision as it is, then probably we would discuss having a peripheral iridotomy, because obviously if you do any form of dilation, their risk of going into angle closure is much higher.
Okay, and from the same optometrist who asked that question, is that you also mentioned preservative-free eye drops. Mm-hmm. Cost-wise, they're a lot more expensive. So do you routinely give all your patients, do you start them on preservative-free, or 100%. Do you start them with...
No, always preservative-free. Honestly, they're not that much more expensive, 100%. Hand on heart. When you look at the cost, don't look at just the cost of the drug itself. And this is a conversation that I have a lot of the GPs, and I've had the pleasure to speaking to quite a few of them and talking on CCG panels, etc. Don't just look at the cost of the medication that you're giving the patient. That actually in itself is probably only marginally higher. Look at the number of times that patient's going to come in because they are non-compliant with the drug that they're giving them, the number of visits they're going to have to come to hospital. And we've had all these patients, and GPs rightly so complaining, saying, why have you given them this medication and 3 months later you give them another medication and 3 months later you give them another medication? Because every time they come in, the pressure is not being controlled. But it's not being controlled because they're not taking it, but because simply they're not taking the drops because it's not comfortable. So if we start at a good starting point with comfortable preservative-free drops, and further down the line, again, now having seen the results of patients being on 20 years plus worth of drops and having to undergo filtration surgery that essentially sadly fails because their conj is just shot to pieces, it's just simply heartbreaking. And those patients will then end up going blind, and there's a cost to those patients going blind. So it's not just the drops, it's the overall cost of the whole thing, and hand on heart, totally justifiable.
Thanks, Sally. Someone's asking, we're seeing a lot more laser PIs at 3 and 9 o'clock positions.
Oh yeah.
So what is the clinical reason for this? Yeah,
there's more. That's more fields related. So the main issue with laser peripheral iridotomy, as many of you know, if you've had any patients coming in with it, is they get this visual aberration. So they get light diffraction break through the hole. And Moorfields did a study about 5 years ago, and interestingly found that when they put the laser temporally or nasally, this was less likely to happen. It doesn't make any sense in my head, but apparently it's got to do with the tear film and the lid position. And if you just position it just at the lid margin, that's when you get the most amount of breakage of the light. And actually, if you put it at 3 and 9 o'clock, that's less likely to happen. So then they recommended that the PI should be moved to 3 and 9 o'clock, although they did say at the time when it's being performed, because that's where the vessels and the nerves come into the eye, it is a lot more painful. So the patient did experience a lot more pain. So that's a Moorfields teaching thing. That's why you're seeing a lot of them at those positions now.
Is that where you do yours now?
No, I still do them at the top, and it's absolutely fine. I think I agree in the sense, if you're going to do them, the word peripheral is literally vital here. It really has to be as far out as possible. Check the lid position. I always check the lid position. So if for some reason the patient has proptosis and the lid is retracted, then again, talk to that patient about, higher possibility of having that light diffraction, and just really place it as far away as possible from the lid margin, as high up as possible. And actually the PI itself doesn't have to be large. It's not size that guarantees the outflow. It really just needs to be about 50 microns in size. It doesn't need to be huge. There doesn't need to be, there was about 15-20 years ago that they have to be very large. You had to put at least about 2 or 3 of them to be working, but actually that's not true. A small PI is just as effective as a big one.
Thanks. So these questions keep coming. We've got quite a few to get through, so we're going to go through quickly, if that's all right. Sure. A quick question on laser trabeculoplasties.
Yeah.
Someone's read a study that initially they're effective in reducing patients' IOP, but over time they're less effective. Is there a reason for this?
It's just the way SLT actually works, again, this is all theoretical and no one 100% knows, is the idea that it causes just a sub-threshold level of inflammation to encourage the macrophages to come in and eat up any debris that's sitting in the trabecular meshwork. So actually, if someone ever undergoes SLT, there's nothing to see. You don't physically see anything. The angle doesn't look any different afterwards. So if you can imagine, the effect of that over the years wears off, i.e. the debris builds up back again into the trabecular meshwork and the pressure starts going up. In most cases, the pressure reduction basically can last up to 5 years, and the treatment is repeatable. Now, we know the efficacy is less every time you repeat it. So at the moment, the current guidelines is if it works for up to a year, then you can definitely repeat it. But then we know the second treatment will probably only last for about 9 months. You can even do a third treatment, and that will be 6 months. And then after that, you're probably then looking at alternative options of treatment. But it can buy you up to 5 years being drop-free, and the IOP will be absolutely fine.
Thanks, Sally. The differences between NHS and private, any differences with MIGs or drops or anything?
So I think the difference with that is basically depending on your surgeon. And, if we're talking about the NHS, it depends on the trust that you're in. Certain trusts have everything available. I'm very lucky within the Western Eye that pretty much all the kit and the MIGs that I use privately, I use within the NHS, I pretty much mirror my practice. And the same again applies when it comes to the preservative-free drops. Obviously, if that doesn't apply to every single surgeon out there, because you are restricted within the NHS of what's available. So for instance, if you're in a unit where they don't do MIGs because it's not something that everybody does, you'd have to put in a business case if you have decided to start using them on your patients. So you argue your case and then they may or may not accept. So that's really the main restriction of what's available. Or you may have some but not the others. But otherwise, that's really probably the limiting factor there, and waiting times, obviously, as always.
Thanks, Sally. How about anything for normal tension glaucoma?
So normal tension glaucoma is like a whole different world altogether, I think, because even though it kind of comes under the bracket of glaucoma, it's actually a different kind of disease altogether. It's more of a vascular disease as opposed to a pressure disease, even though we keep looking at the pressure. So the theory behind it is actually ocular ischemia, so optic nerve head blood supply reduction, which causes the tissue to die in the first place, as opposed to a high IOP, hence the normal tension glaucoma. So that's why they're the group of patients that have, the other symptoms that go with it. So usually Raynaud's, migraines, headaches, etc., stuff like that. And then we do what's called a 24-hour blood pressure monitoring. So you check for nocturnal drips in their blood pressure. So a lot of them are on antihypertensive medication. And what happens is their blood pressure drops overnight, and that causes the ischemia of the optic nerve head. So that's one of the first things to look at. In theory, all the IOP lowering medication is available for these patients, but unfortunately, if we're talking about, like I said, a 30% reduction, well, if your starting pressure is 30% of 30 is a high IOP drop. But if your starting pressure is 18, you're only really going to be dropping them by about 2 to 3 millimeters. And that sometimes, actually, in most cases, simply not enough. So if they are progressing despite the pressure being lower, I tend to have a much lower threshold for bigger filtration operations for these patients, because we are then aiming for a 50% reduction, with really you're not going to achieve without a big filtration operation, most likely trabeculectomy.
Thanks, Sally. How about ocular hypertension? would you advise all these patients to have SLT?
Yeah, 100%.
Or what's the baseline IOP? What would you do?
No, I would, I think with ocular hypertension, again, you quote them the study, like I said, glaucoma surgeons love their studies. There's an ocular hypertension study that looked at natural progression of these patients over a 5-year period of time. And again, 90% of those patients, nothing happened to them. But in the group that did progress, if you did treat them, the risk went down by 50%. So, 10% goes down to 5%, and I just put it to the patient. Now, there's a couple of risk factors that the study identified that increases the risk of progression, say positive family history, very high pressures, large cup disc ratio, and thin corneas. So if you put it all together and you do a kind of an educated, calculated guess of what are their chances of progression, and then based on that, I tend to recommend either treatment or watch. If they are going to be treated, I would definitely start with SLT because they have very little to lose and hopefully quite a lot to gain.
Sally, a bit of a case study, just a small one though. An elderly patient who has developed corneal surface disease and reduced vision from the IOP drops. What's the next line of treatment?
Yeah, so happens all the time. So again, it depends on how bad their glaucoma is and how much medication they're on. If we're talking about moderate glaucoma with not such severe pressures, then essentially a MIGS will be the first thing that I would go for. The kind of important point to make here, doing a MIGS doesn't then prevent you going on to do bigger filtration surgery if they are still required. It doesn't decrease its efficacy, it doesn't increase the success rate of the operation, but it's a much smaller operation with a much quicker recovery process. Now, if they have severe glaucoma with very high IOPs and you simply don't think you're going to win with a MIGS, then they will need filtration surgery. Actually, quite a few of those patients I then pre-treat with dexamethasone preservative-free to try and allow the surface to calm down as much as possible, and then give them oral acetazolamide tablets to control their pressure if it's suitable, if their kidneys are fine and liver, etc.
Thanks, Sally. How about for screening purposes in day-to-day practice? Sometimes it's quicker just to do a macular map of an OCT opposed to a disc one. Is that suitable, or do we need to?
Yeah, no, I mean, everybody knows that, a lot of people are now looking at macular OCTs for early glaucoma defects, because especially in the kind of the inferior quadrant within the macula, that's where the massive neurofiber bundle travels. So you can pick up very early changes within the macula that can suggest disc changes. It then comes into monitoring. How easy is it to monitor? And it's not something that people normally do as a glaucoma specialist. They still naturally, we just divert straight to the disc. But as a screening, absolutely, it's something worth considering.
Something more on the basis of ocular hypertension. Sally, is the first line of treatment now going to be SLT, do you think? Is that what everyone's doing?
Yeah, so I think that's what everybody's doing. But again, we go back to the point of NHS versus private in terms of availability of the actual machine. Not every unit within the NHS does have the SLT available. And I think until NICE changes the guideline, which it will, I think, just based on the studies and everything that's come through, the evidence is just so strong. Then again, people who don't have the machine will have the leg to stand on to put in business cases to buy them. Now, the nice thing about SLT is, like I said, you've got very little to lose and a lot to gain for a long period of time. And it's not just keeping the eye drop free and the IOP well controlled, but it's the number of visits when they come to clinics, the number of times they have to see you, and the endless changing medication. So it's much less pressure on the service as a whole and on the patient. So really, it will change the way we practice, I think, definitely going forward.
We just time for a few more, if that's okay. So when we're measuring angle depth in an anterior OCT, where's the best place to measure it, nasally or temporally?
Probably nasally, because that's going to be the point where it's the smallest, so that will give you a better idea. Whereas if you measure it temporally, it may give you a false reassurance that actually the angle's open where it isn't. So always aim for the smallest possible point, because that will be your point of reference of the chances of them going into angle closure.
A question on high IOPs. If we have patients coming in with high IOPs, what's our cutoff for not dilating, even if they've got open angles?
30.
Yeah.
Okay. I mean, theoretically, with open angle, dilating them is really not going to make a big difference to their pressure, because they've got plenty of space for that iris to move into. If you think about it, the reason why the pressure goes up with dilation is essentially mechanically the iris moves out into a drainage angle. If it's already crowded because it's a small angle, the pressure goes up. if you've got a wide open space, nothing happens when you dilate them up. But really, if they have a pressure of 30, I wouldn't worry about anything else that's happening in that eye. I'd send them in to have someone to have a look, double check the pressure, normally within a safe setting. If they then wish to dilate them up, possibly even after treating them, so they can treat the pressure first and then dilate up the patient and have a look if still required.
Thank you. Sally, I'm going to go for the last question because we are running out of time now. How do you know which patients are going to scar over? So we mentioned the Zen implant and scarring. How do you know who's going to scar?
So usually it's the high scarring rate, younger patients, because obviously they've got a very stronger immune system, male, Afro-Caribbeans, and people that have used preserved drops for a long period of time. Previous ocular surgery or previous trauma, so if the eye's been subjected to any kind of immune reaction in the past, or they have a predisposing allergy anyway. So patients who have atopy, for instance, again, they mount very severe allergic reactions. So that's kind of conversation I have with the patients when they do come in. Like I said, with all this kit that's available right now, it's almost can get too confusing and too noisy. But like I said, you tailor make it to the patient. So you can say to them, well, this one might work, but actually because of your X, Y, and Z, I would much more recommend you have option B, which might be a bigger operation, but ultimately a better option for you. So that's why. So the Zens, for instance, tend to work very well outside of London. So a lot of the patients, for instance, within a Caucasian catchment area with fairly stable glaucoma anyway, who undergo cataract surgery and they have a Zen, they do really well with it.
Thank you, Sally. Before I say goodbye to you and do the poll, I am just going to share my screen, if that's okay. There's just a couple of slides I wanted to go through.
Sure.
The first one, let's see if we can play this. The first one is that our optometrist, Kiva McGovern at OCL Vision, has kindly organised a charity run that we were doing. So if any of you would like to donate to this charity, it's taking place on June the 11th, and we're going to either run 5K or 10K. Sally, you're running, aren't you?
Yeah, I'll be there.
Guru anyway. The link for sponsoring is available on our socials, so Facebook or Insta, if you'd like to donate. Our referral portal, as you know, is available on our website. So if you do have any patients that you'd like to refer, please go online, and at the bottom of every page, there'll be a refer your patient. We do glaucoma packages. Someone has asked me a question just now. So there are glaucoma packages available for any patients that would prefer to have private treatment, and Sally is there at OCL Vision. And you can look at the prices there and see if that suits. Our specialties, as you know, we do most of the eye now, front, mid, back. We've got Ramesh, Alon, and Ali who do anterior. We've got Sally, glaucoma, Shah, Lorenzo, Chen. Between them, they do all of retina. And we have Susan who does our oculoplastics. Our WhatsApp group, I know many of you are now members of our WhatsApp group, but for those of you that are joining today and are new, we have an educational WhatsApp group. So all our consultants are on there. So if you do have any questions or any real life patient case studies and you'd like to know what's going on or ask for advice, the optometrists on all the groups are fantastic as well at answering any questions that we might have. It's nice to help each other out time to time. So there is the QR code. If you can't log in with that, just send me an email at pulvia@oclvision.com and I can send you the link to join our WhatsApp group. We hope to see you there. And finally, we have our next webinar, and that is with our very own Mr. Alon Barsam. He will be talking on Monday, the 21st of June at 7 p.m. And that's on surgical solutions for presbyopia. It should be a great one. I will post this on the WhatsApp group for those of you who remember when it's near the time so you can join, and we hope to see you there. I am going to start the poll actually. So if you could all take your time just to answer these questions, that would be fantastic. Your feedback is always highly valuable to us. So if you do have any extra points or anything that you suggest that we could do, make it better, or topics that you'd like to hear more of, please do just let me know. And we do try and get everything covered as much as we can. Sally, anything further you'd like to add while this poll is going on?
No, just thank you very much for everyone for logging on tonight. And I know we may have not got through all the questions. So if there's anything else outstanding and you're on the WhatsApp group, please put it on there and I'll answer it for you, or just contact Pervia, and then I'm again more than happy to reply.
Thank you, Sally. We are nearly there. I think we have most of the people have added their verdict. Right, I am going to leave it there. Sally, thanks again so much. That was a really fantastic webinar. I have learned a lot. So
Pleasure.
I look forward to seeing you back in clinic to answer any of those extra questions that we didn't get through. Have a great evening, everyone. Thank you so much.
Thank you. Good night.